It's a parasacral probe position with the sonoanatomy. Moving to the GT-IT approach, probe between the GT and IT, seeing the sciatic nerve. Then infragluteal approach. It is the most superficial approach below the gluteal muscles. Then sciatic nerve scanning in the mid-thigh location. Sciatic nerve at the popliteal sciatic location. Longitudinal scanning of the sciatic nerve in the mid-thigh showing alternate hyperechoic bands and clearly visible nerve echo texture. Coming to the complications. So complications should be differentiated from the side effects of the block. Complications are unexpected, whereas side effects are often anticipated consequences. Complications may be permanent or devastating. Side effects are typically temporary and manageable. Complication must be avoided at all costs, whereas side effects can often be handled with vigilant monitoring and patient reassurance. Complications can be divided into those that occur during the block and after the block. During the block, the complications include injury to the nerve, vessel and muscle, leading to neuropathy, hematoma formation and myotoxicity. Local anesthetic systemic toxicity, especially due to higher vascularity in the proximal location. So always aspirate before injection. Inject in small aliquots. Keep the extension tubing end open to check the blood backflow. In case the needle tip enters the small blood vessel, that may still show negative aspiration. Be cautious about the bowel, visceral or vascular proximity anterior to the sciatic nerve in the parasacral approaches, separated only by the pelvic fascia. After the block, complication includes infection, prolonged block or delayed recovery, masking of acute compartment syndrome, pressure source especially at the heel due to an insensate foot. Parasacral blocks may cause weakness not only in hamstrings but also in adductors or even quadriceps, especially when higher volumes are used, potentially affecting lower lumbar plexus nerve like obturator and femoral nerves. Bladder incontinence is possible due to pudendal nerve involvement, but urinary retention can occur if hypogastric plexus also gets involved with the pudendal nerve, particularly with the higher volumes or bilateral blocks due to parasympathetic blockade. So what are the limitations of the posterior approaches? They can be time consuming. Probe stabilization can be challenging, especially in bulky or obese patient. Obtaining an optimal image can be difficult due to the depth of the sciatic nerve, especially in the proximal approaches, multiple overlapping muscle layers and structures with the similar echogenicity. Additionally, airway access becomes difficult, particularly in emergencies when the patient is in prone or lateral position. Positioning assistance may be required to stabilize the patient for difficult approaches. This technique may be impractical or unsafe in patients with spine fracture, morbid obesity, hemodynamic instability, pregnancy, or patients who are mechanically ventilated. To conclude, master the anatomy to master the block. Always match your approach with the indication, the patient condition, the surgical requirement, your personal experience, and the available assistance and equipments. Don't just give it a try. Make it a clinical decision rooted in the understanding. Always keep patient safety in the mind, especially concerning anatomical vital structure in the deeper approaches. These are advanced block with steep learning curve. So practice, practice, practice until you become better, better and better. Always follow ASRA guidelines, especially for deeper blocks where curvilinear probes are generally used, where you are dealing with the highly vascular area. Also, the adrenaline is helpful as a vascular marker in the proximal approaches, but should be avoided in the thigh level blocks due to reduced vascularity, which may cause prolonged or unpredictable effect. Using higher concentration of the local anesthetic can cause hamstring weakness and weakness of all muscles below the knee. This makes such block unsuitable for ERA's protocol. Therefore, parasacral block is the best reserve for the awake hip or pelvic surgeries, often along with the lumbar plexus block. For thigh or knee surgery, GT-IT or subgluteal approach is appropriate for both analgesia and anesthesia. For below knee surgeries, choose infragluteal or popliteal approaches for both analgesia or surgical anesthesia. Thank you all once again for your time and attention. Remember, The sciatic nerve teaches us more than anatomy. It is a quiet guide to resilience, direction, strength in unity, and value of protection. Like its deep roots in the sacral plexus, our foundation shape everything we become. So always remember your roots.